It's different.
Yeah. So you can close all of these.
Wait, close what?
Can you close all of these PowerPoints?
Yeah, yes, I do.
Thanks, Joe.
Okay. Yeah.
I was like, honey, can you run and just go get a bag?
Oh no, I didn't leave yet. I'll pack up the table. It's so pretty.
Sorry, guys.
No, you're totally fine. Thanks for hanging in there with us.
Thanks so much.
Sweet. Thank you so much.
Good. All right, hi guys. Sorry about that. Bit delayed start. That's all right. My name is Viet. So another one of the fifth years. I'm just going to talk through PEDS, ID, and Endo for you today. First of all, big thanks to MUPPITS for putting this weekend on. It's really great that they've put this on for you guys for revision purposes. Thanks. Cheers. Just a few disclaimers before we start. So 2 topics in an hour is going to be a bit of a whirlwind tour. So I might just skip through a lot of the slides. There's a lot of content on my slides. So I'll just try and go through the key things. And if you want, you can have the slides later for revision purposes. So apologies if it feels like I'm going a bit too fast, but here's what we're going through today. So first of all, an approach to febrile child, talking about some viral infections, meningitis, and let's get rid of that, and some immunizations as well. And then moving on to endo, which is mostly diabetes and a few other things as well. Cool. So first of all, approach to the febrile child. So a febrile child is a very common presenting complaint to many GPs and emergency departments and hospitals. Most children are quite usually only mildly unwell. And your goal is to detect serious causes of the fever without trying to subject the kids to too many investigations. And just remembering that a fever is a physiological response mediated by the CNS rather than an illness in itself. The physiological benefits of a fever include delaying the reproduction of growth of bacteria and viruses, and also enhancing immune function. But consequently, you also get discomfort for the child, as well as increased demands on the metabolic system and a whole bunch of other stuff. So in terms of measuring temperature, rectal temperature is actually the gold standard, but obviously oral and tympanic temperatures are more convenient and obviously preferred in many hospitals. A fever itself can be classified into 2 categories. So fever with source, so that's where a clear site or sites of infection are indicated or identified, and a fever without source, basically where you can't really, or you don't really know where the infection is happening. If the fever without source prolongs for a few days, that becomes a fever of unknown origin as well. So considerations for providing education for parents. So really important to emphasize that fever is just the response rather than an illness itself, and most of the time the illness will be self-limiting and benign, so there shouldn't be too many concerns. General management of fever includes rest, restricting activity, and ensuring adequate fluid rehydration as well. And you can use antipyretics for discomfort, most commonly paracetamol. So just lots of simple things for managing fever in general. In terms of the assessment, so your overall goal for assessment is to find the source or sources of infection. So in order to do that, when you take a history, obviously you'll do your whole systems review or multiple systems reviews of many different systems. So you think about RESP infections, GIT infections, urinary changes, rheum and MSK infections as well. And don't forget about the general symptoms, so irritability, being off their feeds, and drowsiness or altered conscious state. Other general things to think about are sick context, travel history, and immunizations. They're also very important parts of the history for fever. Examination-wise, general appearance and behaviour is actually quite a good indicator of potential presence of a serious infection. And you also want to determine overall whether the child is well or unwell, because that will help dictate your management plans and your disposition. So signs of an unwell child include poor interaction, crying, cyanosis, tachypnea, poor peripheral perfusion, and those sorts of things. And again, through examination, you want to examine multiple systems. So do an ENT exam, feel the tummy, have a listen to the chest, and that sort of thing as well. So this is a sort of pathway for management of fever. In general, the younger kids, so kids under a month old, generally you want to be leaning towards more investigative, side of things. So doing your full sepsis workup and then admitting them potentially for empirical antibiotics. Once they start to get older, so between 1 and 3 months, you can consider discharging them home without admission if they do look well, if all of their investigations are normal, and that sort of thing. And once they, get a bit older after 3 months, then you can start to consider sort of discharging them home without doing too many investigations. So, in general, the younger they are, the more likely you are to want to admit and investigate. All right. So moving on to viral exanthems. So they're classically 6 diseases or 6 viral exanthems of childhood described. So we'll just go through them briefly. The first one is measles. So measles is a disease of high virulence and infectivity, and commonly affecting the younger kids, so 3 to 5 years old. How it works is the RNA virus suppresses the T cell response, which increases susceptibility to various respiratory tract infections and diarrheal infections as well. And it's spread by the respiratory route. So clinically, there will be a prodromal period of about 3 to 5 days before a rash occurs. In that prodromal period, you'll get these white spots on the inside the mouth and then the buccal mucosa, known as Koplik spots, which look like this. And then you get the characteristic 3 Cs, so conjunctivitis, coryza, and cough. So just look out for those in your EMQs. And they'll generally be quite irritable as well. Then when the rash occurs a couple of days later, it'll be typically behind the ears and then spread caudally, so on the trunk and then the limbs. And it'll be a generally maculopapular confluent rash, sort of looking like that. When the rash appears, the child is typically miserable, but the fever resolves quite quickly. Okay. So unfortunately, a lot of these viral exanthems can present quite similarly. So with roseola infantum, 6 disease, which I'll talk about in a second, the rash can often be identical. But with roseola infantum, the differentiating factor is that when the rash appears, the fever is resolved. And the child is typically well with the rash. So remember, measles is miserable with the rash, so M for M. And as you can see, there's a whole bunch of other viruses that can cause very similar rashes as well. So unfortunately, it can be hard to differentiate. Investigations-wise, you can do a nasopharyngeal swab for rapid antigen detection or serology for more sort of slower detection as well. Treatment is generally symptomatic, and a lot of the treatment for many of the viral exanthems is just symptomatic, supportive. Rarely is there sort of a specific indication for treatment. So just advise the parents of those topics we discussed before. You can consider vitamin A if there's a serious illness, and antibiotics only indicated generally for bacterial complications that occur. And of course, you've got the vaccine for prevention as well. Moving on to scarlet disease or scarlet fever or second disease. So this is a toxin-mediated disease caused by group A strep. Basically, the group A strep acts like a super antigen and bypasses the usual HLA presentation of the antigen to T cells. And this affects sort of the older kids, so 5 to 10 years old. Clinically, they'll have this characteristic sandpaper-like rash. I don't know if you can see that picture very clearly, but apparently it does look like a bit like sandpaper, I guess. Might be itchy, very confluent as well. And you also get the strawberry tongue. Just a quick note, be aware that some buzzwords are present for multiple conditions. So strawberry tongue is also actually a buzzword for Kawasaki's disease. So just watch out for that. And they might have a circumoral pallor, so a ring of white pale skin around the lips. Investigations-wise, you can do a throat swab, and serology will reveal a high ASOT titer or high anti-DNA ASB titer as well. Treatment-wise, in this case, you can give oral penicillin, which does help, but otherwise, again, it's mostly symptomatic treatment and relief. Rubella is the disease. So this is quite rare nowadays due to vaccination, as are a lot of these viral diseases. The main sort of concern would be in congenital infection because it can cause a range of fetal complications as well as congenital rubella syndrome. Again, typically the older kids, so 5 to 10 years old, and non-immune pregnant women as well. And typically the incubation period would be about 2 to 3 weeks. then they'll be infectious a couple of days before the rash, they'll get the rash, and then they'll be infectious after that as well. So it's quite a long period of infectivity for rubella. Clinically, I like to think of rubella as measles' little brother. So it's typically a more mild disease. There is a rash which is quite similar. So it starts on the face and then spreads down to the neck, trunk, and limbs. But generally, it will be a more faint, less profuse rash than measles itself. And you might also get some lymphadenopathy. So more mild. Again, for investigations, if you've got a non-immune pregnant woman with questionable exposure, you want to do serology, and that can identify the presence of rubella. And again, no specific therapy, just supportive and conservative management and prevention with vaccine, of course. Right, so moving on to erythema infectiosum, which is slap cheek or fifth disease. So caused mostly by parvovirus B19 and can affect kids with a wide range of ages, so 3 to 10. And can cause epidemics in school and family contacts as well. So you'll get the characteristics of slap-cheeked family with all the siblings affected. Clinically, they might have some lymphadenopathy, might have a fever, and then you'll also get this characteristic slap-cheek sort of red rash with, again, a ring of pallor around the lips. That rash can actually spread to the trunk and the limbs as well. And you might also get some sort of joint soreness and muscle soreness as well. Generally infectious before they get the rash. Now, quickly, in terms of EMQs, sort of erythema infectiosum and roseola infantum did climb up quite a bit in past EMQs, and I always got confused between the two. So to help you remember them, I've told a quick story there. So imagine you're at a party and you hear this awesome song, and you think, oh, it's got a quite nice bass. I really like that slap end of the bass. It's quite infectious. This party, makes me want to be young again, be 19 again. So just remember, infectious slapping of the bass, B19, parvovirus. I think the more crazy something is, the more likely you are to remember it. So just take it as you wish, or you can think I'm weird, but that's fine. I don't mind. Complications-wise, this virus does actually affect red cell precursors, so that's why you typically might get a mild anemia associated with the disease as well. And this is important because if the kid's got a pre-existing anemia or hemoglobinopathy, that can cause an anemia or aplastic crisis, as well as fetal hydrops if infected in pregnancy. Again, no specific treatment. NSAIDs may be for associated arthralgia or arthritis if present as well. So roseola infantum, which is a sixth disease, so most commonly caused by human herpes virus 6, so HHV6 or HHV7 in some cases. Commonly affecting the younger kids, so infants around 3 to 18 months. Generally, the incubation period will be about a week or 10 days. Then they'll get a fever, and as we described before, once the fever resides, the rash will then appear. Okay, so very important to remember that clinical story. Clinically, they'll also get the generic sort of fever, infective symptoms, irritability, a very similar rash to measles as described before. There's an increased occurrence of bulging fontanelles and febrile convulsions associated with roseola infantum. Again, no specific treatment, just supportive and resting at home, fluid rehydration, that sort of thing. To help you remember roseola infantum and human herpes virus, imagine you're driving down the M1 freeway, the Monash, because you're doing lots of roadworks at the moment, you're doing 40 kilometers an hour, which is really annoying. But then as you're driving past, you see a girl from school and you recognize her name's Rose, and she's wearing a high-vis top. So Rose wearing high-vis, roseola infantum, human herpes virus. Take it as you will. So those are the 6 diseases. So moving on to other viral infections. Varicella chickenpox caused by varicella zoster virus, or a type of herpes virus. Very highly infectious disease, spread by the respiratory route. Can affect kids from a wide range of ages. And generally, these kids are infectious until their last skin lesion dries off and crusts over. So the incubation period is about 2 to 3 weeks. Then they'll get a prodrome of about 1 to 2 days, a very short prodrome. Then they'll get that characteristic rash, and then they're infectious until that last bit of rash dries off and crusts. Clinically, that prodrome will include things like fever, a bit of anorexia and lethargy. Then you'll get the characteristic, hundreds and hundreds of vesicular bullous lesions that generally crust over 3 to 5 days. and may result in scarring later in life as well. Apparently, they can be described as a Joan Rose appearance. I was a bit skeptical at first, but then I put these two pictures in, and I guess in the vesicular, very sort of bullous phase, it does kind of look like a dewdrop. I mean, again, debatable, but it can cross placenta and cause neonatal varicella as well. Generally, a clinical diagnosis with the rash being a bit more characteristic than the other ones, but you can PCR the virus and do serology for that as well. This is a very complicated diagram of a management pathway for chickenpox. The general gist is if there is sort of pre-existing risk factors or severe signs or symptoms that might increase the risk of a serious infection, then you generally want to lean towards admitting for monitoring and acyclovir, basically. So, say if they've got say if they're immunocompromised or they've got features of cellulitis, if there's mental state is impaired, then you're generally wanting to admit for IV acyclovir or some other treatment as well and monitoring. If they're all clear and it's generally an uncomplicated infection, then you can just discharge them home from hospital with advice and supportive therapy again. So that's generally just that. Complications, basically a wide range of bacterial complications can occur. So skin, pneumonia, encephalitis, and hemorrhagic chickenpox as well, which is quite rare. And as we all know, the virus can remain dormant in the dorsal root ganglia and reactivate later in life as shingles. And as we mentioned before, acyclovir only if there's a severe disease or risk of severe disease. If it's an uncomplicated infection, then you can generally just discharge home with supportive management. Right. So infectious mononucleosis or glandular fever is caused by Epstein-Barr virus, typically a disease of adolescence because it's transmitted by infected saliva via the oral route, so known as the kissing disease. Clinically, the differentiating features would be splenomegaly and lymphadenopathy. So as well as these palatal petechiae, which you might notice in the back of the mouth. They might have a subtle rash, which becomes florid if given amoxicillin as well. So that could be a very characteristic story for an EMQ as well. Investigations-wise, you can do serology again. The monospot or Paul Bunnell test basically are detecting antibodies from proliferation of polyclonal B cells. And on a blood film, you'll get atypical mononuclear cells as well, hence infectious mononucleosis. In terms of advising for treatment, so you want to advise these kids to avoid contact sports until their spleen is not palpable anymore, because there is an increased risk of rupturing the spleen. And you can consider steroids, I guess, in some circumstances if the tonsillar hypertrophy causes a severe form of airway obstruction. Moving on to hand, foot, and mouth disease. So enteroviruses overall, they're a group of viruses spread by the fecal-oral route. Generally can be classified into three major types, so Coxsackie viruses, echoviruses, and just to confuse you more, further enterovirus types. And basically they cause a wide range of clinical infections affecting a lot of different systems. Basically, the main one we'll talk about today is Coxsackie disease, hand, foot, and mouth disease, which is caused by Coxsackie, A16 most commonly. Affects preschool and early school kids, and the clinical features are quite obvious because it's in the name. So you get a blistering rash on the palms of the hand, soles of the feet, and inside the mouth as well. And the rash can be either maculopapular, or vesicular. You also get sore throat, high fever as well. Very highly infectious, but it's very self-limiting. So for treatment, just advise staying home and avoiding sharing personal belongings, ensuring there's hand hygiene at home as well, etc. So to remember hand, foot, and mouth disease and Coxsackie virus, also there's a picture of the blisters in the hands and feet and mouth. I remember Dean Cox. So Dean Cox is a West Coast Eagles ex-West Coast Eagles football player. He played in the AFL when there were 16 teams in the league. And to play football, he used his hands and his feet, and I guess his mouth as well. So Cox, 16, hand, foot, mouth. All right. So I think Dinesh yesterday touched briefly on Kawasaki disease as part of his cardio lecture. So I won't labour the point too much, so we can skip briefly over this, but just emphasising again, it's more common in Northeast Asian boys. His mnemonic was quite different, so I used warm cream. So warm being the prolonged fever for 5 days, C being conjunctivitis, R being the polymorphous rash, E being the erythema of the palms and soles with desquamation of the peripheries, A being cervical lymphadenopathy, and M being inflamed mucous membranes. And then there again is that buzzword strawberry tongue, so watch out for Kawasaki disease and scarlet fever. And generally they'll be very irritable as a kid. Treatment, basically IVIG and low-dose aspirin are the sort of mainstays. And aspirin is because of the risk of coronary artery damage, especially coronary artery aneurysms, which is quite common if they're untreated. But by treating them, we can reduce that risk by quite a bit. So IVIG and aspirin, and watch out for aneurysms. All right, so we've got a few EMQs from your past, the practice papers available. So we'll just go through them briefly. A 3-year-old boy presents with 2-day history of fever, malaise, and reduced appetite. Today he has developed sores in his hand and his mouth. Anyone shout out the answer? B, yep, so hand, foot, mouth disease, ulcers on his hands and mouth. Yeah, it's not too, it's not exactly rocket science, so that's fine. 4-year-old boy presents with 2-day history of fever and mild generalized joint pain. Examination has bright red cheeks. Yep, so bright red cheeks, slap cheek, infectious, slapping of the bass, great song, everything infectiosum. Good stuff. 2-year-old girl presents with 3-day history of high fever. Fever's now resolved, but she has now a widespread rash mainly on her trunk. G, yep, roseola and phantom. So remembering that story of the rash appearing as the fever subsides, that's a very important clinical story to remember. Take another one. So a 3-year-old boy presents with a 4-day history of fever, widespread rash and conjunctivitis. Noted to have white spots on his soft palate. Measles, yep, so got that C for conjunctivitis, part of the 3 Cs, and the white spots are Koplik spots, which we talked about before. Great. Okay, so moving on to meningitis. So that's most of the viral stuff covered. Meningitis is typically a life-threatening condition, so often needs rapid recognition and treatment. And generally, you'd want to be considering meningitis as a differential for all of your febrile and sick kids. There's various risk factors involved to determine whether it's determine the severity of the disease, I guess. So environmental things, genetics, and micro factors as well. Etiology, so the causative agents differ between the age groups. So the younger kids below 3 months, the most common causative agents are E. coli, Listeria, and Strep agalactiae. Once they get older, so past 3 months, you'll get the more typical pneumococcus and meningococcus, so Strep pneumoniae and Neisseria meningitidis. And there's HIB as well in there in the kids between 3 months and 5 years old. Okay. Presentation-wise, I'll have, they might present with a non-blanching particular purpuric rash, particularly if it's meningococcal, and a fifth or about a third of the kids will present with convulsions as well. If they're on the younger side, they'll have more non-specific symptoms on presentation, so things like drowsiness, fever, irritability, vomiting, poor feeding. Once they get older, they start to develop the more specific characteristic symptoms of meningitis that we all know. So photophobia, neck stiffness, and headache. So just be aware of that. Investigations-wise, so lumbar puncture is your key sort of investigative tool for identifying the presence of a meningitis. Very high sensitivity unless antibiotics have been commenced before that. If antibiotics have been already started, a PCR of that CSF or blood culture is also quite useful. In general, you want to be careful of doing a lumbar puncture if they've got specific symptoms, so papilledema, seizures, or any neurology, because there is a risk of coning, cerebral herniation, if a lumbar puncture is performed then. But the general gist is don't delay treatment. So basically, if you do suspect meningitis, treatment should be commenced as soon as possible in a general sense. You'd also want to do all your other bloods, so FBE, monitoring electrolytes and blood sugar levels. And CT is not typically recommended as a first line. So lumbar puncture is the main thing, and bloods as well. This table just summarizes the sort of main findings on lumbar puncture for bacterial and viral meningitis. So for bacterial, the main cell type will be neutrophils. Because the bacteria use up the glucose will be reduced, and there'll be elevated protein as well. For viral, the predominant cell type will be lymphocytes, and typically the glucose and protein will be either normal or very slightly elevated otherwise. In terms of antibiotic treatment, so for empirical antibiotic treatment for meningitis, which is the sort of things you want to start straight away, from the guidelines, they recommend ceftriaxone, benpen, and vancomycin as well. So those three are your friend, mostly ceftriaxone and benpen. Once you identify the specific bug or causative agent, then you want to consider more sort of targeted therapy. But as you can see, most of the bugs are covered by benpen anyway. So ceftriaxone and benpen are your friends. If they're under 2 months, so if they're still sort of quite young sort of infants, then the guidelines say that they're treated in a different pathway, and that's when they use cefotaxime and amoxicillin, which is sort of wrong there, but that's right. But just remember ceftriaxone and benpen are the most important things. As well as that, regular monitoring, of course, IV fluids. Steroids have been shown to be beneficial if initially if there is unknown etiology, and seizures that occur, you want to treat those as well. So there are various complications that can occur with meningitis. So things like convulsions, intellectual disability, hydrocephalus, and deafness. So that's why most kids go for a hearing test after an episode of meningitis. And future behavior and learning problems are unfortunately quite common as well. Prevention is via vaccines for most of the causative agents, and you can consider antibiotic prophylaxis if there is increased risk for family or childcare contacts. Places like that. So meningococcemia specifically, basically this is always septicemic, and sepsis is a predominating presentation and needs to be managed. So along with the generic symptoms of meningitis, you also get maybe severe limb, abdo, back pain, very pale skin and cool extremities, and often shock in the end as well. The rash can progress from a blanching macular papular rash to a more severe diffuse petechial purpuric rash, as you can see here. And this is rapidly progressive in terms of how fast the kid actually deteriorates. So very important to recognize fast. And circulatory collapse is the major cause of death. So to manage that, you want to admit to ICU for aggressive fluid resuscitation. Antibiotic-wise, benpen is your friend, again, according to the guidelines. And with that, you'd also want to be managing your electrolytes and glucose levels as well. Viral meningitis, so weirdly enough, also known as aseptic meningitis. To distinguish viral meningitis from encephalitis, you look for an absence of altered conscious state and focal neurological signs. Those are the main key features differentiating those two. Otherwise, viral meningitis, very similar investigations to bacterial meningitis, which we just talked about, and it's typically more benign with recovery in a few days to a few weeks, and mostly supportive treatment for that. So encephalitis, main clinical features, again, altered conscious state, focal neurology. If they've got any of those two, you'd be more suspecting encephalitis rather than viral meningitis. Meningism, so photophobia and nextphthisis is actually frequently absent in encephalitis. You can also get, if the spinal cord does become affected, you can also get areflexia, paralysis, and the neurogenic bladder as well. Investigations-wise, PCR, lung puncture or viral culture, serology and MRI is actually indicated in this case as well. Treatment-wise, acyclovir is given initially, but otherwise, again, it's supportive management, so for encephalitis. Right, so touching briefly on tropical diseases, these were in your curriculum matrix, but I think the likelihood of them being examinable is relatively low, so we can just skim past them. Just remember for malaria, causative agent, most common causative agent is Plasmodium falciparum. Investigations-wise, thick and thin blood films. And treatment is basically anti-malarial drugs. So quinine or ACT, which is Artemether combination therapy. And prevention with bed nets and mosquitoes, repellents, and that sort of thing. Dengue, so dengue is more like your flu-like illness with aches and pains, a rash, and just other flu-like symptoms. Can present with, severe dengue can present with dengue hemorrhagic fever and dengue shock syndrome. But in general, the management will be supporting circulation and replacement of coagulation factors. My friend who just did an elective in Samoa did say there was an outbreak of dengue fever. So if you are considering doing an elective in Samoa, just a heads up that it does exist. So, but in terms of exams, it's probably not going to be too examinable. All right, so for some more EMQs, 13-year-old girl presents to the ED with a 10-hour history of fever and drowsiness. On examination, she has evidence of shock and a widespread petechial rash. So quite sick. Which antibiotic would you use? Ben-pen, yep, so Ben-pen is your friend, probably meningococcemia, quite sick, so you need IV therapy. Ben-pen is your friend. Ceftriaxone, I don't think is an option there anyway, so. 9-year-old boy recently from Bali had diarrhea. Stool sample reveals Giardia lamblia. So probably not sick enough for a hospital admission, like maybe depending, quite vague. Anyone want to have a go? Yeah, so metronidazole in that case. I guess that's the only one that makes sense. No mention of rectal metronidazole in the guidelines, so I don't know why that's there, just maybe it's the red herring. 2-year-old boy with constipations noted to have a circumscribed patch of erythema around his anus. Colleague thinks it's a strep infection. So again, seems quite vague, but I'd be assuming that kid's not sick enough for a hospital admission, so oral therapy. So which oral agent would you use? Strep. J, yep, so penicillin. Penicillin strep infection. It's pretty simple. I think that was that. Okay. Any questions so far? Any queries, concerns? No, cool. So moving on to immunization. So talking about immunization, passive immunity is basically where you acquire preformed antibodies from the maternal source. Active immunity is the process of immunization, so administering the vaccine to provoke that immune response, similar to a naturally acquired infection. In terms of the vaccination schedule itself, I guess it is ideal if you do know it. But again, thinking about the likelihood of examinability, it's probably, again, considering you have all this other stuff to study for, it's going to be quite low on your priority list. So, and unfortunately, if you are going to learn it, it's just going to have to be rote learning the whole schedule. So to help you remember, I've got another story. So when you're born, the first song that gets sung to you is a Hep B birthday. So Hep B birth. Then at 2 months, so 2 months in, because you're a med student, you're very keen and you're down to practice some Oskies. And Harry Potter's also happens to be on TV, so you watch Harry Potter for Hep B and polio. And what Oski stations are you going to practice? Because you have to do third year Oskies as well, you practice your HIP examinations and your PR examinations. So HIP and pneumococcal rotavirus. And you do that every 2 months, so 2, 4, 6, because practice makes perfect. And then you get to 1 year old, so 12 months, and you think, oh, dang, I'm 1 year old. I'm on top of the world. I might throw myself a birthday party. I might move my hibs like an MC, so meningococcal C. Then we go 8 to 6 months later. We take a history lesson, and we learn about the famous battle of the 3-letter acronyms, MMR versus DTP, with chickenpox thrown in there somewhere. And then fast forward to 4th year. So 4 years old, you're in 4th year. You better be down to practice Oskies. So DTP plus polio. And then high school, you've got chickenpox and HPV. So again, take it as you wish. In terms of immunization administration, again, this is probably not too examinable. Just things to remember are sites used for vaccinated kids, the thigh and the deltoid. Want to be avoiding the butt to reduce risk of sciatic nerve damage. And there's not contraindicated to, so vaccines are not contraindicated to allergies, current antibiotic treatment, or controlled epilepsy, or if they've got a minor ERTI or low-grade fever. So if they do have any of those, vaccinations are still okay. There's some special circumstances if you want to consider extra vaccination as well. So travel, asplenia, and that sort of thing. Okay, so that's basically all of ID in a very, very brief nutshell. Moving on to endo. So if you don't remember anything else, because it's probably almost the end of the day, I'm the second last lecture, just remember diabetes. Diabetes is the main thing for endo. If you remember nothing else, just diabetes. Because it is quite common, and it's rising in incidence, so you'll see more and more of it as you go into the profession. There's a variety of factors, etiological factors involved in diabetes, and remembering type 1 is an autoimmune process, so destruction of the beta cells of the pancreas causing insulin deficiency. Because it's autoimmune, it's also associated with other autoimmune diseases, so thyroid, celiac, and Addison's as well. Clinically, for type 1 diabetes, you get this very classic triad of polyuria, polydipsia, and weight loss. So if that's anywhere in an EMQ stem, just think diabetes straight away. And if the diagnosis isn't made till later, there is an increased risk of presentation of DKA. So that includes vomiting, abdo pain, more sort of dehydrated illness as well. Can progress to coma and death if not treated or not recognized. Diagnosis will typically be a raised blood sugar level, sugar or ketones in the urine. If they're unequivocal or if the clinical picture is not very clear, you can consider a fasting blood glucose or HbA1c to look at the blood sugar control over the past 3 months. And because it's an autoimmune disease, antibodies can identify the presence of type 1 diabetes. So anti-islet cell antibodies or anti-GAD antibodies are markers of that destruction of the B cells. Factors that might make you consider type 2 more include if a family history of type 2 diabetes, if they're severely obese, and apparently kids of Indian background are more likely to develop type 2 diabetes for some epidemiological reason. In terms of insulin types, so insulin is the mainstay of treatment for type 1 diabetes. You've got your rapid-acting insulin, which is Humalog Novorapid, short-acting, which is Actirapid, and that's commonly used in DKA treatment. So an Actirapid infusion is commonly run for DKA kids. Intermediate-acting, which is Protophane and NPH, which is less common nowadays, and the long-acting, which is Lantus and Levemir. You've also got predetermined preparations of mixed insulins as well, so short and intermediate commonly. In terms of injections themselves, they can use a variety of sites, so arms, thighs, abdomen, buttocks, but you want to be rotating those sites to prevent fat hypertrophy, which you could look for an examination if it's an OSCE. In terms of insulin regimens, so there's 2 or 3 main insulin regimens used nowadays. The first one will be the basal bolus regimen. So this regimen involves 3 to 4 injections per day. Basically, the kids get rapid-acting insulin before meals, so that's your bolus. And then before bedtime in the evening or in the morning, you'll get a long-acting insulin, so that's your basal. The advantages of this regimen include that there's greater flexibility with meal times because you're relating the boluses to your meals. But with that, because you're receiving more injections a day, it does require quite a high specialist input. And you'll need to have a really supportive school environment as well because you're doing injections during breakfast and lunchtime, so when the kids are at school. The other common one is a BD regimen, so BD, so twice daily. Basically, there's only 2 injections, so 1 in the morning, 1 in the evening, and those are injections of pre-mixed insulin and combinations of insulin as well. The advantages are that obviously there's less injections for the kid, but with that, there'll need to be more strict and rigid meal times, which some families might find quite difficult. And some kids nowadays are on an insulin pump, which is basically a subcut sort of pump, which is providing a continuous infusion of rapid-acting insulin, as you can see here. So those are the 3 main ones: basal bolus, also known as MDI, multiple daily injections, the BD regimen, and the insulin pumps. Another mainstay of type 1 diabetes management is education. So education for the family, parents, and the child, very, very important. And generally, once the kids are admitted to hospital, they'll receive a very intensive education program, most commonly done by diabetes nurse educators. So it's very much like your pre-clin days when you had lectures from 8 to 6. They just get slammed and slammed with the constant education. So the things that get educated about, obviously, what is diabetes? How does it work? What is insulin? How to inject and how to rotate insulin injection sites? How to monitor blood sugars? What changes need to be made in the diet? How to treat hypos, and where to get advice as well. So a lot of the work is done by diabetes nurse educators these days, which is good. Blood sugar monitoring. So you want to be aiming for blood sugar of between 4 to 6. If there is a change in the routine, so if, say, if the kid's sick or if you're on holiday, you want to be aiming for more frequent testing. And ketones as well if they're sick to avoid DKA. And HbA1c every 3 months, aiming for about less than 7.5%. Features of hypoglycemia include sort of feeling a bit weak, wobbly and shaky legs, feeling a bit dizzy, sweating and hunger and abdo pain, and can commonly present as a hypoglycemic seizure and maybe coma if left untreated. To treat hypoglycemia, basically just give them sugar. If they can tolerate oral intake, glucose tablets or oral glucose gels. If they've got an unconscious state or can't tolerate oral intake, give them IM glucagon in that case. The hormonal changes in puberty and adolescence actually antagonize insulin. So throughout that phase of growth, their insulin requirements actually increase. Unfortunately, teenagers are less likely to adhere to insulin and dietary regimens. Complications-wise, it's the classic complications that you would have known about, as well as potentially obesity and delayed puberty, specifically related to growth, and regular review of podiatry and opthal if needed as well. So DKA, so what is DKA? Essentially, the definition is in the name. So diabetes, hypoglycemia, so high blood sugar, greater than 11. K is ketosis, so ketones in the blood or urine. And A is your metabolic acidosis, often with a high anion gap. Basically, when you've got a lack of insulin, you can't use the sugar because it's not in your cells. So the body decides to break down ketones instead. The thing is that ketones are an acid, so when you break it down, you become acidotic, hence ketoacidosis. So DKA happens when kids don't take their insulin. So often they forget, or there's a change in routine, or they go to a party and drink alcohol, and that just messes the whole thing up. So investigations-wise, you'd be wanting to monitor blood sugar levels, ketones, and blood gases for the acidosis, as well as your electrolyte levels and LFTs and other bloods. What happens to the sodium? So sodium initially goes low, but then because of the excess fluid loss and that sort of thing, the osmotic diuresis, there's an eventual hypernatremia. For potassium, the total body potassium begins low. However, with insulin and fluid therapy, what that does is actually push potassium into the cells, reducing that blood potassium level even further. So that's why potassium is given in some circumstances as part of your DKA treatment. The management of DKA can be remembered by this mnemonic. So SPIDER, S for saline, P for potassium, I for insulin, D for dextrose, E for nil by mouth or enoxaparin, and R for reason. So basically, these are the main sort of management principles in order. So first of all, you want to fluid resuscitate with saline, maybe give potassium if indicated. Then you commence your insulin, then maybe dextrose as well, to prevent the blood sugar from dropping too low. Throughout the management of DKA, you would be wanting to monitor electrolytes and blood sugar levels, as we previously discussed. And the main complication we worry about in DKA is cerebral edema. So cerebral edema can occur if the fluid shifts too rapidly from a too quick correction of the fluid, of the electrolytes. So you'd be wanting to monitor those electrolytes quite carefully. I've tried to do sort of piece fluids in one slide. So basically, the first thing you want to do is with a dehydrated child is to estimate the fluid loss. And this is done in categories based on what their clinical presentation is. So if they're quite mild and relatively well, then you can say it's a mild dehydration between 0.5%. A moderate dehydration, which is 5 to 10%, is when they have more of the dehydration symptoms. So delayed cap refill, mucous membranes are dry and they're thirsty. And severe dehydration is 10% or greater than 10%. And that's all of the above symptoms with signs of hypertension, and tachycardia. To calculate the fluid deficit, so the three things you want to consider for fluid, so the fluid deficit, maintenance fluids, and ongoing losses. So to calculate the fluid deficit, you multiply the weight by the percentage of fluid loss, which you have estimated here. For maintenance fluids, there's a 4-to-1 rule, which you might have heard about by now, which is 4 mils per kilo for the first 10 kilos, 2 mils for the second, and then 1 mil per kilo for the rest. That gives you the maintenance fluids, or the rate of maintenance fluids for the hour. The 150-20 rule is essentially the same thing, but gives you the overall maintenance fluids requirements for 24 hours, which is mostly more convenient in, I guess, most circumstances. So, but it goes by the same principle. So 100 mils per kilo for the first 10 kilos, 50 mils per kilo for the second, etc., etc. And for ongoing losses, you'd be wanting to try to measure the losses, so whether they be urinary losses or vomiting losses as well, and then replace those slowly over the same time that they were lost. So those are the three broad categories you can consider with fluids: the deficit, maintenance fluids, and ongoing losses. If urgent resources is required, you just go straight to bolus, which is generally a 10 to 20 mil kilo bolus. All right, moving on to the thyroid and other stuff. This stuff, thyroid is very much similar to adult thyroid disease. So not much is, different. For congenital hypothyroidism, there is screening done in Australia for all newborn babies within sort of 2-3 days of life, along with PKU and CF. The most common cause is abnormal formation of the thyroid gland itself. So agenesis or an ectopic thyroid somewhere. Among the classic symptoms of hypothyroidism, they might present with a failure to thrive, which is specific for PEDS. So just look out for that on an EMQ. Investigations-wise, you do your TFTs and a thyroid ultrasound, and treatment is basically thyroxine replacement. Acquired hypothyroidism, less common than congenital hypothyroidism. They might present with the triad of obesity, short stature, and mental dullness, and retardation of their growth, but otherwise very similar classic presentations of hypothyroidism. Investigations and treatment are largely the same, with larger thyroxine doses generally needed, and the prognosis overall is very good with long-term treatment. So, hyperthyroidism, generally it's always maternal because of the transplacental passage of the antibodies. Clinically, they might present with poor weight gain, along with tachycardia, irritability, and the other classic hypothyroid symptoms. Again, investigations, TFTs. Treatment is much the same again. So beta blockers for symptomatic control, carbimazole, so anti-thyroid medications, and sedation in some cases if they're particularly irritable. Acquired is more commonly due to autoimmune disease like Graves' and more common in adolescent females. Features are similar with plus or minus the other classic symptoms of hypothyroid. So heat intolerance, anxiety, sweating. Investigation same, treatment largely the same, with the addition of a radioactive iodine or thyroidectomies. Congenital adrenal hyperplasia basically is a condition where there's impaired production of glucocorticoids, mineralized corticoids, and there's increased production of sex steroid hormones, and most commonly caused by 21-alpha hydroxylase deficiency. The main presentations will be either early virilization in females or in boys, salt losing. And typically the treatment is just replacing those hormones. So replacing the glucocorticoids and replacing the mineralocorticoids as well. Okay, lastly, touching on growth. So various factors are involved in growth, but the major determinant is genetics, as well as nutrition and various hormones involved. Various phases of the growth. So fetal being the most rapid phase with rapid enlargement of organs and tissues. Childhood starts to plateau to about 5 to 6 centimeters of growth in height per year. And then you've got puberty with the onset of sex hormone production as well. But just remember, genetics is the most important factor. How do we assess growth? So we assess growth by using growth charts, which I'm sure you've all seen by now. Median final height for males is about 176, for females about 163. But you're not too concerned about the actual measurements, the individual measurements themselves. You're more concerned about the growth velocity, which is more important. And normally a child should develop along the same centile. A bone age scan is done by doing an X-ray of the left wrist and hand. Basically, that's an indicator of physiological maturity, and it's a guide to the remaining growth potential left in the child. And a mid-parental height is an estimation of a kid's final height based on their parents' heights. Sorry. So there's the calculations there. I don't think you need to remember them, so don't worry too much about those. Short stature is basically height below the third centile, or growth deceleration as well. Main two causes are familial and constitutional delay. So familial, basically, I guess there's a family history of being quite short in the family. The growth velocity is actually typically normal, and most kids will have puberty at a normal time, and the bone age scan will also be normal. Whereas constitutional delay, they'll be short during childhood, but then once they reach adult height, they'll be consistent with their sort of mid-parental height expectations. Often there's a family history of that story, so being quite short as a child, but then catching up later on in life. And puberty and bone age may be delayed in these circumstances. Then there's the rest of the other causes of short stature, which are much, much less common. So main two are familial and constitutional delay. To work up with the history examination, you do your assessment of growth, and bloods only if you suspect a chronic disease or chromosomal abnormality. Treatment depends on the cause. You can give growth hormone in some circumstances. So if they're growth hormone deficient, or if they've got Turner syndrome or Prader-Willi syndrome as well. Tall stature is less common, less likely to be a concern for parents. Height above the 97th centile. Most common cause is familial or genetic tall stature. So the parents will often be quite tall as well. You also want to look out for precocious puberty, so early puberty. Generally, these kids will be very tall, sort of early to mid-childhood, but then relatively short once they reach their adult height. And to treat that, we just switched off the premature activation of that HPG axis with hormones. Then you've got the other rare causes of tall stature, so the genetic syndromes and the endocrine causes as well. Lastly, for puberty, I guess just knowing what's normal puberty is, I guess, the key thing. So for females, the onset of puberty is between 8 and 13 years. Early puberty is quite common and often constitutional, but late puberty for females is quite rare and often needs investigation because it's often pathological. For males, the onset is between 9 and 14 years. Early puberty is less common, and late puberty is usually just constitutional and less suggestive of pathology, so you're less worried and less likely to investigate. Okay, and just to finish off, we've got a few more EMQs. So 13-year-old boy parents are concerned about his growth. He's always been the shortest in his class, but recently the gap has widened. His father tells you he was also short at the same age, but now is of average height. Yep, sounds like a constitutional delay. Perfect. 9-year-old girl presents with short stature. Mother tells you she was growing well up until 2 years ago. Performance at school has dropped and she's become constipated. Yep, so constipation, poor performance at school, probably there's not much there in the stem, but those two will be classic hypothyroid symptoms in a kid. So that's hypothyroidism. And I think that's it. So thanks very much for listening to me, guys. I know it's a bit of a whirlwind tour. I want to wish you all the best for your exams. So I know you smashed them. So good luck, all the best, and thanks. No worries. Oh, thanks so much. No worries. No worries. Thanks, buddy. No worries. Good. Hope it wasn't too rushed.
No, you did well. And thanks for covering endo as well.
No, that's right.
Because we didn't have it before. Hey, sorry we're running late.
No, that's
today.
all right. That's all right.
It's the last one, so hopefully you still have their attention.
I doubt I will, but that's okay. I should take less than 45 minutes anyway.
Okay, perfect. I feel like just give them a minute.
Yeah, no, everyone's left the room. Hopefully some people will come back. Maybe not, who knows?
How's your weekend been so far?
Yesterday is Jewish holiday, so I was originally scheduled for yesterday. It's a really bad day. I have to fast for a couple of days. So it's been a really bad weekend. I hope we're really good. How's the
Does the
revision?
holiday change each year? Is it
Yeah,
based on
yeah.
a lunar calendar?
Yeah,
So it's not always on the long weekend?
No, it's
Okay,
not,
cool.
but it's very often at the exact same time.
Oh, is it? I'm like, that's not great timing.
But how's the revision?
I think it's been really well. All the feedback I've had is people have really enjoyed it.
You know, last year's it was really good.
Yeah.
It's a shame that only PEDS does it.
Yeah, well, yeah. We're hoping that might change in the next couple of years. So we'll see. Yeah, and you're live streaming as well. So the mic's for the live stream, and then the one on top is for the students.
That's good. So is that for the rural
The
people?
rural students, yeah.
Where are they streaming from?
Gippsland, Bendigo.
I should say hi to the people in Sale, given I was just there.
Yeah, give them a shout out. Right. Another minute and then get started.
Very quickly losing a lot of people.
I think people just really need money.
Yeah, that's it. Maybe they just saw the one urology and left.
Yeah. All right, guys, we might get you to take a seat so we can get started soon.
I'll just stall until everyone comes in. We seem to have lost quite a few people in the break. All right, so those of you who don't know me, my name is Nathaniel. I'm also a final year who's been roped in to give this lecture. Not exactly the most pediatric enthusiastic person there is. If you looked at my pediatric rotation attendance, it's quite abysmal. But that said, I think the reason in part that I'm happy to still give this lecture is that, as hopefully someone's communicated to you guys until now, PEDS is that one specialty in fourth year that people are actually, like, the faculty is nice to you, they write nice exams, and you can still do quite well without even studying that hard. I didn't, as I said, didn't really attend my pediatric rotation all that much, didn't buy a single PEDS textbook. Should I be advertising this? Didn't buy a single PEDS textbook, and did probably the least amount of studying for PEDS out of all the 4 areas, and it still was by far my best in the exams, which... hi, James. Yeah, late. All right, so what I'm basically trying to say is attending this weekend is probably almost enough pediatric studying as it is. And you should feel pretty confident that if you know all the buzzwords, because the MCQ really at the end of the day is just 50 buzzwords, and the OSCEs are only on the big conditions. So if you know the basics of pediatrics, you really are all set. You know, you can memorize basal bolus regimes for insulin if you really want to, but I'd highly discourage that. There's a lot more important places to be dedicating that kind of focused attention. PEDS, they just want you to know the basics. All they want to know is that you'd be a safe intern for pediatrics. Let me make this clear. I'm not saying that you should be going into your exams feeling great, just the pediatrics exam feeling great. Okay, if you're feeling great about all your exams at the end of fourth year, either you haven't done women's health yet or you're delusional. But pediatrics is the one area that really, if you just know the buzzwords and know the basic conditions, the only place to know details is probably PEDS RISP, asthma, and hopefully that's been communicated. Every other specialty really stick to the buzzwords, and that's probably enough. A small plug for Humorous Hacks. Who here, put your hands up if you listen to Humorous Hacks? Great. Their pediatric cardiology thing is basically all of PEDS cardio in 1 hour. Listen to that podcast, it's amazing. But anyway, so moving on to pediatric neurology. So the OSCEs, there's really only 2 things in OSCEs that you can get when it comes to pediatric neurology. It's either going to be headaches or seizures. They're not going to give you an OSCE on anything else that is just way too complicated. For the MCQ, there's usually quite a few buzzword conditions, but really you just need to know a bit about them, what they are, not, management in any detail. So this is a very superficial lecture, but it's really all you need to know at, fourth year Monash pediatric level. If you're from another university, I don't know why you're here. So anyway, or another year level, then, get out. So if there's any third years in the audience, anyway, so we had a headache OSCE last year. I'm not sure if anyone's told you that yet over this revision weekend. It was taking a headache history from the parents. It's really almost every one of your PEDS OSCEs. It's going to be a parent-based one. There was one video OSCE that we had last year. And that was obviously they videoed the kid and not a parent. And it was basically a bronchiolitis versus croup OSCE. It was very, and that was pretty much the hardest OSCE station there was. Someone's probably told you this. Bronchiolitis versus croup was the video. It was very clearly bronchiolitis, but a lot of people thought it was croup because they thought bronchiolitis, that why would they take a video of it? They overthought it. It was a bronchiolitis video, but because it was so difficult and they had a double printed page that most people only saw the first page, they end up having to scrap the OSCE because depending on where you were, either there were 2 pages or 1 double-sided page. So the one hard PEDS OSCE, they got rid of. So the average PEDS OSCE mark last year was 77, which is pretty high for OSCEs, and the average written was 88. So really, you can do very well in PEDS with minimal studying. Study women's. Please, for the love of God, study women's. Anyway, so the headache OSCE we had last year was just a history taking and then explaining it to the patient. That's all that it was in the history. And really, my approach to pediatric headache, it's very much the same as adult headaches. It's not that much different. So this is, straight out of my slides for year 3 neurology revision of how you all the causes of headaches split into basically how the temporal onset of them. Is it the most important thing with any headache is it a new and acute onset headache? Is it something episodic? Or is it something that's been getting slowly but progressively worse? Episodic, there's episodes of terrible headache and then person's better, bad headache, better, as opposed to a very slowly worsening headache or a just sudden onset, really, really bad headache that has just gotten worse over, one day or in some cases a few hours. So it's the same headaches for PEDS. There's just a few things that you can kind of get rid of. So extradural hemorrhages are really just a post-trauma thing. So if the kid got hit by a cricket ball, then obviously that might be in your differential list. But if there's no serious trauma before the headache, it's not an extradural. Subarachnoid technically can occur in pediatrics, but it's not really. Temporal arthritis, you need to be over 50, so that's definitely not PEDS. So really the only new and acute onset headache to really be thinking of in a PEDS OSCE is going to be meningitis. And really, as we should go through meningitis, you should be able to tell it's meningitis that stands out from everything else pretty clearly. Episodic acute headaches, cluster is really more older, 20s or so, late teens, tension. Yeah, everyone gets tension headache, but are they really going to give you an OSCE and tension headache? Probably not. So really the episodic headache to worry about in pediatrics is just migraine. And then chronically, progressively worsening headaches. Again, subdurals technically can occur in, your young child who's being shaken by a bad parent. But it's not, again, they're not going to present in headache because these children are obviously not going to be the ones being able to complain of headache in any case. So it's not really that much in your differential list. Anyhow, it's usually more of a trauma multi-presentation. So really, your chronically progressing, getting worse headache over a period of weeks or months is going to be increased intracranial pressure. And the only real cause in the child is going to be a brain tumor. Benign intracranial hypertension is usually, women in their 20s. So really, you can kind of narrow down a headache differential diagnosis in pediatrics to 3 main conditions. And your OSCE is basically about ruling these 2 out and diagnosing them with migraine because it's going to be migraine. That's what we had last year. That's what they had 3 years ago. It's always migraine. So like I said, it's about boiling down to this thing. And it's actually not that hard to tell all of these apart. So does anyone want to volunteer? What questions would you ask? How would you tell apart without skipping to the rest of the slides, which you all have? So without cheating, can anyone tell me, hands up, how would you tell all of these guys apart on the history? Everyone? Sorry? Yeah, I can't see where that's coming from, but yes, fever, cool. Yeah, everyone point at him. Cool, yeah, fever, which one's fever? Fantastic. Migraine causes fever. Yep, absolutely brilliant. I can't even make a joke on that one. You just dug it for yourself. Yes, so meningitis is what you're trying to say, I hope. So yeah, meningitis will probably have a fever. The other 2 really shouldn't. In particular, a migraine I don't think you'll ever find with a fever. Anyone wants to volunteer a better answer? Perhaps a correct one? Anyone wants to say anything? Now no one's ever going to say anything after that. Yeah, anyway, so let's just go through it. So migraine, not a fever. What things do you find in migraine? Anyone wants to shout out a few things you'd expect to hear or see in the migraine history? Aura? What's an aura? Yeah, okay, so you ask the parents, has the child had any weird stuff beforehand? A few specific auras. Like, can a child tell you that they have... Depends on the age, yeah. So it's a less of a PD thing. That's definitely a real, like, adult thing of that rising butterflies in your stomach. Usually the children that you're going to see in these OSCE stage, maybe they'll be able to explain the deja vu. That's also more of a seizure aura than anything. The rising butterflies. I mean, you can technically get anything with a migraine, but it's more of a seizure. Any other more? What's the classic aura for a migraine? Yeah, flashing lights, scotomas, visual stuff is the classic, but technically can be any neurological symptom. You can get a migraine where someone goes hemiplegic before their migraine. You can get anything really, any neurological symptom. So an aura is definitely one, although most migraines, common migraines, don't have aura. Anything else? What things do you see in migraine? Nausea, vomiting, perfect. Photophobia and phonophobia. So photophobia you see with migraine, but you also see that with meningitis and subarachnoids, whereas phonophobia is kind of only really a migraine thing, particularly in exam questions. Real life, yeah, probably if you've got a raging subarachnoid hemorrhage, you won't want to listen to loud music. But absolutely, phonophobia. Anything else anyone wants to say about migraines? Throbbing, cool. So I should just ask you, do you want to just describe a migraine? No, okay. That's all right. You're doing better than fever next to you. So headache, usually an older child. Migraine tends to be girls. So the patient we had last year in the OSCE was a 7-year-old girl. Strong family history as well, usually in the maternal one. So that patient we had, like last year, her mom had migraines and her mom's mom had migraines. They couldn't make it, more obvious. And you really should ask about the mom's type of headache. So if the dad, because it was the dad that brought them in, so you say, oh, does anyone else get headaches in your family? He said, oh yeah, my wife does. Oh, do you want to tell me? You have to ask, can you tell me more about the headaches, just to get an idea that they're all migraine headaches. So family history, it's a recurrent episodic headache. Like I said, it's the same every time as well. And usually severe throbbing, commonly unilateral, can be bilateral headache, photophobia, phonophobia. There's no residual neurology when well. That's really important. So if the patient had a headache on Tuesday and on Thursday they still have hemiplegia, that is not a migraine, right? So there shouldn't be any ongoing neurological symptoms. But the aura, which can be any neurological symptom, can certainly be a part of the migraine. And there are many triggers to headache. You don't need to go and ask every single one. There's the chocolate mnemonic that you learn in 3rd year. It's not really necessary to ask here, particularly because half of them don't really apply to children. But you certainly should ask if there's anything that they've noticed sets off the headaches. And just remember that there are abdominal migraines. And you know what an abdominal migraine is? Anyone? I think it's abdominal pain. Cool. Anyway, so you just ask that they get the child in the OSCE had like abdominal pain every so often, and you just need to know that it's not anything more important, serious than just an abdominal migraine. They really made it very clearly migraine in the OSCE. Whereas hydrocephalus, which in PEDS is always a space-occupying lesion. Anyone wants to tell me what the features of the headache are? Yeah, can have a visual field defect depending on the amount of hydrocephalus, sure. Definitely the worse in the morning, worse lying down because it's high CSF pressure. So if you're standing up, it goes down. But if you're lying down like you've been overnight, the headache gets worse. Also worse with coughing, anything that increases intracerebral pressure. So often they might be younger. It's chronically progressing. So the important thing is that this doesn't come in episodes because their brain tumor doesn't just come up and then go back down. Tumors don't do that. So it's going to be a headache that's getting worse. And the most important things to ask in your OSCE is it worse lying down? Is it worse early in the morning? Is it worse with coughing or sneezing? The OSCE is not going to be about brain tumor management. The OSCE is going to be about migraine, but you need to show the examiner, pretend that you thought about these things. So you ask all of these questions that you're going to get a no to, but you ask them nonetheless. And the headache that wakes up a child is also another buzzword for something more serious. Nausea and vomiting as well, but this is going to be worse in the morning. confusion, and any progressively worsening neurology that often points to where the headache, to where the tumor is. So if there's any motor signs, it might be a frontal lobe or brainstem. If there's any cerebellar stuff, probably cerebellar tumor. So you just ask a general, you should do in any headaches, ask a neurosystems review. And in this case, with a tumor, it's going to be, maybe a neurological deficit that's getting worse, like they're being ataxic. The parents will say they've had worsening balance over the last 3 months about the same time as the headache, or worsening vision, or worsening weakness on one side of the body, or a bit of a tremor, something like that. Double vision as well, really commonly too. So it's just important to know that. And any change in behavior or academic performance in pediatrics, as you guys should know, is a red flag. So a tumor in a kid, so a kid that's just having slowly worsening academic performance, that'd be a cognitive side effect of the tumor. So that would also be worsening neurology, particularly in children. Papilloedema, a big sign for hydrocephalus, of course, as you guys should know. And then, and just constitutional tumor stuff. And then lastly, meningitis. This is the one that has a fever. Meningism, triad as well, of headache, photophobia, neck stiffness, plus fever. This is an acute onset one-off headache. So they haven't been going on with bacterial meningitis for 3 weeks. It's a recent kind of thing. They're very commonly in peds. They really spell things out. A widespread non-blanching papular rash of meningococcal septicemia. So they will often throw in rashes, and the kid might be from Afghanistan. Again, I'm just going to stress this. I'm not being racist, but that's exactly what they do in the MCQ to kind of hint at the child not being vaccinated. If they do update the exam, maybe they'll say they're from Byron Bay or something. But they want that two-step process of our child's from place without vaccines, so they might have meningococcal, which you should be vaccinated against, and obviously osteotic contact. This is a very different OSCE. This is a febrile illness OSCE more than if it was actually meningitis. But you should rule out meningitis. Ask about fevers and rashes in almost. I actually said fever and rash in every peds OSCE history I had. It was just. Never hurts to ask. It's always kind of relevant, and children can only do so many things. So, you ask if they have a fever and a rash, because that's almost every peds illness anyway. So it's probably good to ask that and rule this out and show the examiner you're thinking about it, but it won't be, if it's just a headache OSCE, it won't be meningitis, but then it could be a actual febrile illness meningitis OSCE. That'd be a different story. And you should know, how to manage meningitis. So the approach to a history OSCE is, WWQQAA, but also really, really understand the timeline, because that's really how you're going to be able to tell apart the migraine to tumor. Any association, so if the female patient, more likely migraine, menstrual cycles, an older child, family history for the phonophobia, migraine, whereas, as we said, worse lying down in the morning and coughing is a tumor. So this is probably like the most important thing to tick off in the OSCE. And then just do a general neurosystems review as well, plus all of your PEDS questions, of loss of weight, change to appetite, toileting, et cetera, and, developmental regression stuff. So that's basically how I'd approach the history OSCE. Last year, they didn't even want management. They just wanted you to get an idea of what the patient had and then tell the dad that it's just a migraine, it's nothing serious. And so the OSCE was basically a very obvious migraine. Most classic story you could have. What would be your next step to the dad? What would you tell them that you're going to do? Hands up who would order a test. Hands up if you wouldn't. Good. Okay. So if it's a clear migraine, you don't need an MRI. If there are any red flags, obviously you would order an MRI brain. In children, you try to avoid CT scans. The management, again, like I said, management you need to know for PEDS RESP, and like your fluid stuff. That's all you need to know for management. DKA a little bit. We had a DKA OSCE last year, and you need to know the management basics of that. The only thing to know guidelines for is like asthma, croup, bronchiolitis. With this stuff, they didn't even want us to talk about it. All I said was, I think the GP can manage this, and if it gets out of hand, you can refer to a pediatric neurologist. But if you do want to know, obviously a brain tumor management, you refer to a pediatric neurosurgeon, and then migraine, here's the management. If you want to read through it in your own time, there's all these medications. Anyone know why I've written aspirin only for older children? Rye syndrome, good. Okay, awesome. So anyway, it's good to know about the management of migraine, but I'm not going to dwell the point here. So now let's move on to the seizure OSCE. Anyone knows what the differentials would be if you were to get an OSCE where it just says on the stem that the parent brings in a child who's had a fit? Let's keep it vague. Febrile convulsions, good. You really like your fevers. Anyone else? Pseudoseizure in what age? Yeah, maybe an old enough to have psych problems, sure. Yeah, you can tell how much I care about peds. Anyone else? Too many people talking? Yes, or seizure. Yeah, not afebrile seizure. Yeah, cool. Good. Sorry? Absent seizure is a type of seizure, so just keep it on the seizure box. Breath holding attack, great. Syncope. Anything else? Is meningitis going to give a fit? Well, it can cause a seizure, but then it's going to be, is it a febrile seizure or is it a seizure due to meningoencephalitis? That's really complicated territory. So I know you like your infectious diseases, but let's put that to the side. Someone said something else? Okay, what did you say? Parasomnia, sure. Anyone else? Yeah, hypoglycemia, absolutely. There's one more thing that I have on my list here. That's a type of seizure, but yes. Anyway, let's just move on. So you guys have a pretty good list as it is. So it's important to remember that a patient who then not everything that twitches is epilepsy. It's not just because the parent says that they had a fit, that it's definitely a seizure. It could be, anything. At the end of the day, people say they had a fit when they just had a bit of, a vasovagal, or, they just had a bit of lightheadedness and they say they have a fit. So it could be anything. And you really need to be very clear as to what they're saying. But if it's a possible convulsive episode, obviously a febrile convulsion is the first thing to think of, because that's the classic PEDS thing, and 9 times out of 10 your OSCE is going to be on febrile convulsion, because that's, again, they like to ask about benign stuff in PEDS OSCEs, because like 9 times out of 10 when you see a child in ED, it's nothing, and you just send them home, and it's fucking annoying because you want to see real patients. I'm sorry. I had a really bad ED rotation because it was midwinter and I only got to see PEDS patients when I really don't want to do PEDS. Anyway, febrile convulsion is the alternative, as you guys said. And does anyone know what an febrile convulsion is? That just sounds like the stupidest term ever. But does anyone know what this is? That would be a really logical explanation if it was, but it's not true. Sorry? No, because then they technically were still febrile when it happened. Exactly. And what's that infection typically? Gastro, yeah. So it's usually gastro resulting. It's an infection, so it's a response to the infection, but they were never febrile to begin with. So you're not entirely wrong there, but they were never, like if you'd measure them the entire time, they never really had a spike in temperature. Syncope. Well, I think we all know what syncope is. Breath holding attack. Someone said that before. Who said breath holding attack before? Or anyone wants to describe what it is? I feel like it came from over at this area somewhere. Yes, anything? Yeah? Why do they hold their breath? I can't hear your mom. Yeah? So what do upset children do? They cry. So it's, that's just a question mark. That was not, that was a build up for a question mark. Anyway, so yeah, a child who's been crying a lot will might just stop breathing because the crying is apparently more important, and then they can get go blue, cyanotic, and pass out. So that's kind of what it is, and they can twitch as well, because you guys have seen that video of the German medical students who like hold their breath in vasovagal and then they have a faint, but it looks like they start twitching. If you haven't looked at that, look it up. It's amazing. But anyway, breath holding attacks is something children do, and it can look like a seizure. So it's after crying or trauma because the child's upset. Laryngopharyngeal reflux and laryngospasm. I barely know what that means. I just know that it's in the differential and that it's what happens after feeding. So if they've had a feed and then it just kind of, they go into, they get a bit of reflux and it goes into spasm and they stop breathing, also can cause a fit or a faint, but it's not really a seizure. And then someone said psychogenic non-epileptic seizure. Again, that's really going to be more in your later years when because there needs to be a psychogenic precipitant to it, but absolutely should be in your differential list. And then hypoglycemia is always an important mimicker when it comes to seizures. So these are the things you should be thinking of. And these are the different definitions. So basically everything that had a question mark was kind of a new PEDS only thing. And that's what you need to ask about. I will put the full slides afterwards with these answers there anyway, so don't worry about writing anything down. So the seizure OSCE is basically going to involve diagnosing either between a febrile convulsion or an afebrile convulsion, but you should just still ask questions about all of those weird random things, like were they crying before it started, were they eating before it started? You ask all of those questions. You know it's not going to be yes, because they're not going to give you a whole OSCE on breath-holding attacks. But you just ask those questions to, look like you know what you're talking about. Basically, a ped seizure history is the same as any seizure history, but a bit more of those questions. And usually there's going to be a parent who saw it. So different from adults when you don't know what happened, usually the parents can give you a pretty good idea of what happened. Maybe they'll even bring a video into the station. I think that's pretty unlikely, but it's possible. So first thing with any seizure OSCE, has this ever happened before? That's really important because it might, if it's an afebrile seizure, multiple episodes will make you think epilepsy. If it's a febrile convulsion and it's happened every time they've had a fever, that just makes your diagnosis more likely. Before the seizure, was there any triggers? I mean, they're not going to say that their 5-year-old was, doing meth and not sleeping very much. Hopefully, I mean, you don't know. I've worked at Frankson before. Any causes or, auras and any auras in particular before. Again, depending on the child's age, they might not be able to report if they've had auras. And then ictal, and the most important thing to remember to add on is any blank staring, as well as, what did they do? Was there any convulsions or jerks? Any lip smacking or the chewing, the automatisms that you get in seizures. Tongue biting and incontinence is really important because you don't really get that with syncope and other stuff. So that really points you towards a true seizure. And obviously, if the child was conscious during the episode, do they remember it? Depending, again, on the age of the child. That's the problem with a lot of history taking in peds, is that they don't get child actors. So often it's asking the parents. So a lot of these questions aren't even relevant anyway. Unless the parents talk to the child. And then post-ictal, this is one of the most important things, is where they confuse, they recover, bam, all of a sudden they're well. So if it was a breath-holding attack or something else, or a vasovagal, they'll wake up and they'll be back to their normal self. But if it was a seizure, there's always a slow coming back to, there's some confusion, post-ictal stuff, or even temporary weakness or, localized neurological symptom signs after the seizure that really points you again to a true seizure. So it's the same thing with as with adults. The only thing to add, obviously, the first thing to ask is, did they have a fever or any recent fever, febrile illnesses, any gastro symptoms, so nausea, vomiting, diarrhea, for that febrile seizure to talk about. That's something that will just make the examiner think this student really knows what they're talking about. And if you ask about, were they crying or had any trauma beforehand or feeding beforehand, what were they doing at the time, that would really make you look like you've thought about the PEDS differentials. Again, it's going to be a no to all of these questions. But it's just good to look like you know what you're talking about, whereas really you're just sitting there like, all I've been doing the last 2 weeks is memorizing prompt guidelines. So anyway, I really do memorize those. Women's is scary. So anyway, afebrile convulsions in the OSCEs, if there's no fever or a recent gastro, but it's clearly a seizure, that's a serious thing, and you need to look for the cause. So the investigations to consider when the child first comes in is a BSL for ECG, for hypoglycemia, ECG for any arrhythmias or anything like that, an EEG, and an MRI brain. MRI will show if there's any, deformations or tumors which might be predisposing to the seizure or epilepsy that they have. This child needs pediatric follow-up. So remember, the most important thing in a PEDS rotation is knowing how to be a PEDS intern, an ED intern. So not to send this child home without follow-up. This child needs to be seen by someone. If they're well after the seizure, you don't need, to admit them necessarily. But what you need to know is that this is a serious thing, and they need to be looked at by an expert. And if you have 2 or more episodes, that's epilepsy. So epilepsy is 2 or more non-provoked seizures or a known epilepsy syndrome, like one of the genetic ones, but that's a side thing. So they've had 2 or more seizures, that's epilepsy, and that child needs to be put on medication. But what you really just need to know is you need to investigate the child acutely, BSL's ECG, and then consider EEG. If you've got one right there, sure, do it now. But otherwise, outpatient EEG, outpatient MRI, and pediatric follow-up. Whereas a febrile convulsion, anyone wants to tell me what do you do for a febrile convulsion? Yes. Absolutely nothing. Fantastic. Okay, do not go in and investigate these children generally. So as you guys should hopefully have had this drilled into you, Benign convulsions, febrile convulsions are benign. They occur in about 3% of children, 6 to 6. So outside of this age range, it can't really be febrile convulsions. So a 2-month-old with seizures is always serious, even if they have had febrile illness. So, and this is not pathological. And then it can be divided further into simple febrile convulsions. Anyone can tell me how to tell simple from complex febrile convulsions?
Complex lasts longer than 15 or 30 minutes.
15 or 30. Okay, what's coming up on the slides? Anything else? Which ones are focal? Complex, great. Complex recurs. Sorry? No, not even 24 hours. It recurs within the same illness. So if they've had the same bout of inerty or whatever, or a gastro, but they've had repeat seizures within that, that's complex. Simple does recur, but it only recurs in another febrile illness. So they have to have gotten better from whatever infection they had before they got worse. So yeah, that's basically the gist of it. So less than 15 minutes is the cutoff for a simple febrile, and a simple is always a generalized tonic-clonic, and it doesn't need anything. Panadol doesn't help in reducing the likelihood of a seizure, and it's not to be used just to bring down the fever. Why do we need to know that? I don't know, but it's in every RSH guideline, every lecture anyone's ever done about this, so it probably would come up in a marking criteria. So you just need to tell the parents, don't use the Panadol just to bring down the fever. It doesn't help to reduce the likelihood of seizures. Only use it if the child actually needs it for pain or they're not coping, etc., because otherwise fevers are just the body's response to the febrile illness, blah, 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 random crap. You just need to hone in that point, because otherwise parents will just get really intent on reducing the temperature, and that has not been shown to do any difference in reducing the seizure. So complex, like we said, more than 15 minutes, any focal features, so if there's one limb twitching or anything like that, recurrence in the same illness, or incomplete recovery. So remember how they're not immediately well after a seizure. It usually takes minutes or so to get better. They get a bit confused, a bit drowsy. But if it's been more than an hour, that's not normal for a febrile illness. And that may need to be investigated or referred. Basically, you just ask for an opinion. So in an OSCE, you would say, if it's a complex, I'll get the senior person to look at them because there's a few worrying features before we send them home. You don't need to be worried about what to do if it is a complex or not. That is beyond 4th year level. Hopefully no one read too much about that, but during that brief click, anyone to tell me things you would tell the parent about febrile seizures? So we said reassure, it's benign. What else do you want to tell them? Who said that? Good job. Do all of them? Simple ones don't. Complex, there is an increased risk of epilepsy further on. I think it's like 4 to 12. Doesn't matter. Do not memorize numbers for peds. Leave that for women's. Anything else? Yeah, keep the child safe. So the first aid is about keeping the child safe. It's not about restraining them, and it's not about stopping the seizure. That's the most important thing, because parents will think to, put, this was in the Royal Children's Guidelines, don't put them in a bath. For someone to have thought that that's a good idea. I don't know how that came up on the guidelines. But anyway, away from dangerous stuff, on a soft surface. Don't try to restrain them. Don't try to hold their tongue, like those myths that people said that's a problem. They'll choke on their tongue. Don't do that. You just let them seize away, unless it's been more than 5 minutes, in which case that's status epilepticus, and then you need to try to stop seizure. That's when you call an ambulance immediately. But otherwise, soft surface, don't try to stop it. Let it stop on its own. Just make sure they don't get any head strike or injuries as a result of it. Important thing to say is that it's benign. There's no tumor, there's no infection, there's nothing causing this, no impact on intellectual development, no increased risk of epilepsy. Like we said, they'll grow out of it, it's genetic, and it's very common, and that helps to reassure people. And the important thing to know is that if it's been more than 5 minutes or they're not waking up, obviously call an ambulance. Otherwise, still tell the parents to go and take the child to the GP, but don't need to go to it. You don't need to be too stressed about this. And you don't Panadol them up just to try to stop the seizure. All right, cool. So now we're done with the boring stuff. We can just go into random buzzwords, which is, the MQs, and probably what's you're going to get the most out of. Because if there was a PEDS neuro OSCE last year, the chance of it being again this year is small. That said, maybe the 2 of the 4 OSCEs that we had last year were perhaps from 2013 the exact same. That could have been true. And so I would recommend that if you find that document of past OSCEs that someone's written, maybe, that might be helpful. Because they may or may not repeat OSCEs and PEDS, because no one can be bothered writing new ones. Just like women's, 2 of your OSCEs will come straight out of Western. Doesn't mean you'll do well on them, but at least you'll know what's coming. But anyway, buzzwords. So I'll give you guys a minute to try to do all of these questions. You've probably all seen them already because you're in 4th year and you've probably done these exams 7 times. But I'll give you guys a minute. All right. People have stopped looking at the screen, so I'm going to decide this is the arbitrary amount of time that you guys get to do this. So first question, hopefully you all got this one. Anyone wants to shout out what answer you had for this question? Did anyone not get febrile convulsions for the febrile child having a convulsion? Sorry, that was very patronizing. Did anyone actually think there might be something else going on here? Good. Okay. So yes, that's febrile convulsion. Question 58. Anyone wants to shout out what answer you had for this question? G. Some people say infantile spasms. Anyone wants to say something else? You may or may not be correct. So does anyone want to say? Sorry? Dravid? Anyone wants to say something else? So we've got D's and G's here so far. H is juvenile myoclonic epilepsy. Anyone? I mean, I don't just read letters. Tell me things you actually put down. But does anyone want to say anything else? All right. So first of all, let's talk about H. Does anyone know what myoclonus is? Myoclonus tends to be like a single one-off jerk. Like the classic description of myoclonus is, a one arm, like it's the flying plate syndrome of like they have like breakfast in the morning and just all of a sudden the one arm goes like that and plates go flying. Lots of people have had that, probably have that when you go to sleep and you have that feeling that you're falling and you just wake up with like a sudden jerk. So myoclonus tends to be that kind of one-off, maybe localized jerk, rather than a repeating spasm. So that's not what juvenile myoclonic epilepsy is. Juvenile myoclonic epilepsy tends to be older. Juvenile, it's not infantile, which may be a clue to the answer. But the other thing is as well, it's like this is like a stereotyped episode that keeps recurring for several minutes. Myoclonic tends to be a one-off thing, and it tends to be like a morning thing in older children, and it's more benign, whereas this has developmental progress concerns. That's not a benign thing. Anyone knows what Dravet syndrome is? Because someone said it.
Lots of different seizure types over a period of time. They're usually a bit older than 8 months, they're usually sort of primary school age, and they can get atonic myoclonic seizures as well.
That sounds good. I've got no idea. I looked it up and I already forgot because it's really poorly defined. What I will say though is this is a good idea whenever you get these EMQs in your exams. Don't just look at the answers and which ones that are the answer and learn those. My theory is that Monash has one stem for every single one of these A through I. And that theory was proven because if you look at the past exams the faculty's released, Swatchman-Diamond syndrome, have you guys come up with that, across that in the EMQ options? It's never been a question. I looked it up because I was like, oh, maybe they'll have that one, and it came up in the exam last year. So every single one of these in the EMQs, you should know. So you guys should know what Dravet syndrome is. I have no exam, so I don't care. But you guys should look that up in your spare time and try to memorize it. That's, I think, for memory, it's a really badly defined one, but it is older. These are very stereotyped episodes. And this is exactly what infantile spasms are. I've got a slide coming up later, but it's basically this stereotyped drawing up of legs, flinging out of the arms, and hunching of the shoulder and neck. Repeated episodes that happen in very young children over and over, and they are associated with developmental progress. They're really bad. They're called West syndrome as well, or Salam episodes, because apparently it looks like a Muslim person saying hi. I don't know, and apparently neurologists are racist. the bottom line is that these episodes are serious, and the longer you take to notice them and put them on anti-epileptics, the worse the child's developmental progress is going to be affected. And that's what infantile spasms are. So this is basically the definition. If you're going to remember anything about infantile spasms, it's exactly this question stem. And lastly, 59. Does anyone want to tell me what they think 59 is?
C.
All right, so someone's saying C. Anyone else wants to be brave and disagree with C? Anyone have any problems with C or anything that's confusing them? Yeah, the abdominal distension, right? So does anyone have a good explanation for abdominal distension? Good, because I can't think of one. My best bet is that there is a thing called abdominal seizures, which are associated with temporal lobe epilepsy. And that thing is usually more of a pain and cramping that they get cyclically, like a seizure. And this is a red herring to make you think, if someone knows about that, think it might be temporal lobe, but this is just abdominal distension rather than anything else. So my best bet is that it's a red herring to make you think of something that it isn't. Abdominal distension might just be normal in a child. They might just have, a Wilms tumor happening on the side that we don't care about. But obviously care about tumors, people. But what I mean to say is it's probably a red herring. And the most important thing is that these are small pauses in activity, 1 to 3 seconds. It can't be anything other than absence seizure. So even though there's this weird abdominal distension thing, this is the most classic. No other seizure lasts for that little. The only seizure lasts seconds is absence. Brief pause in activity is absence. And subtle lip smacking, minor automatisms like the chewing, the lip smacking is a feature of absence seizures. So this is just a very classic absence seizure. So I'd be hard pressed to choose anything else unless someone came up with a genius idea for what this abdominal distension is. That said, it's not a question that I'm like 1,000% sure on, but I would still be definitely thinking it's absence seizure here. So this is basically that description of the infantile spasms. Again, I'll put up the slides with the answers as well later. Cool. These questions. I'll give you a bit less time because we're meant to have finished by now. All right, for the sake of time and everyone having a bit of a weekend, I'm kidding, you guys are in 4th year, you're just going to study when you get home. Anyway, question 88, anyone wants to tell me what you think for the first one? Some people are yelling out J. Yeah, have I heard anything? Anyone wants to say anything else? Because otherwise I won't go through it if you don't tell me multiple answers. Did anyone have any difficulties with this one or think it might not be J? Okay, I mean, I'll explain it anyway, but it's more, is there any other differentials people are thinking of? So these basically are just a list of A to L of buzzwords you need to remember. That said, I've got no idea what A-beta lipoproteinemia is, but good luck. Question 88. So what have we got here? We've got a very young infant. So very young, usually suggesting congenital things might be the case. Poor feeding, slow weight gain. Well, great. That's every pediatric disease there is because that's the only thing little children can manifest with. Floppy, poor muscle bulk, absent reflexes. Is this upper or lower motor neuron? Lower motor neuron. Put deep tendon reflexes. Fasciculations, lower motor neuron. So we're talking about a lower motor neuron disease. A congenital lack of lower motor neurons or congenital atrophy of lower motor neurons. So if we go through this, options. I shouldn't because then I'll give away answers to all of the other stuff. Basically, this is the buzzword, the definition of spinal muscular atrophy. So spinal muscular atrophy is going to be atrophy of the anterior horn cells, lower motor neuron atrophy, generalized. It's a hereditary condition. It's genetic. Losing, and it just presents with lower motor neuron signs very early on. So it's a child who will have poor tone, poor bulk, and lower motor neuron signs. So is like the floppy child with lower motor neuron signs and nothing else. It's basically the definition of spinal muscular atrophy. So, I mean, it's more, remember this as the buzzword for that more than any decent explanation that I can give. This is just what you should remember for spinal muscular atrophy. But it's as the name suggests, a lower motor neuron problem. It's at the spinal muscular level. 89. Anyone knows what this is? All right. Anyone wants to volunteer a guess? Anyone confused? Yeah, so we've had 2 people say that. Anyone wants to say anything else? Sorry? Friedrich's, oh no, sorry, that's not C. Okay, Friedrich's ataxia. So Friedrich's ataxia is a reasonable differential for unstable walking. How does Friedrich's ataxia present? It's basically just going to be the unstable walking and some leg signs. It doesn't have this ear infection. Ataxia telangiectasia is basically a weird syndrome that I've never heard of until I saw this question. But when you Google it, it makes perfect sense. So Google's your best friend here. Is that it's a syndrome of ataxia, telangiectasia, who would have thought? But the one thing that's hidden is that they've got poor immune function and they get recurrent infections. So it's a hereditary thing, but they get recurrent infections, typically otitis or otitis media, ataxia, and they could throw in that they have lots of telangiectasias, but that might make the answer too obvious. So that's just, again, random peds buzzwords that you would never be expected to see on the ward, but you need to have heard about this once, and once is enough. Do not go and read on the causes and treatment of ataxia telangiectasia. Just be happy that you know what it is. It's these 3 things. Cool. Question 90? Sorry? E, a few people saying E. Anyone has anything else? Maybe people with wrong answers can speak up first, because then I can, feel like I'm making a difference. Anyone has anything else that they thought of? No, they're not febrile. Cool. Anything else? Anyone had anything else? All right. Well, yeah, it is Duchenne's muscular dystrophy. Why? Difficulty climbing stairs, and standing on their feet, slow muscular development, slow gross motor development, and the classic buzzword is these enlarged calf muscles. There's one other sign, a classic buzzword of Duchenne's. Does anyone know what it is? Did someone already do this with you guys? Damn. Anyway, I'll just, you guys can leave. I'll just stand here and talk to no one. It's fine. Gower's sign, which I'll show in a picture, but it's a funny way of standing up because of basically of the particular leg weakness. So there's muscular dystrophy. So honestly, these are just buzzword definitions. And then the last one, does anyone know what 91 is? So someone say J or K? Tuberous sclerosis. Anyone have a different answer? What the fuck's the point of me being here? You guys know everything. Yeah, okay, cool. So let's just go through all of these. Spinal muscular atrophy, like I said, autosomal recessive. Severe hypotonia, which is why it's lower motor neuron sign. So they call it a frog-like posture, no reflexes, and it's usually fatal. This is a very serious condition because they basically have degeneration of all their lower motor nervous system. Ataxia telangiectasia, it's an autosomal recessive neurodegenerative disease, and everything you know is the ataxia and telangiectasias. Who would have thought? But also poor immune system, recurrent infections in particular. Duchenne's muscular dystrophy is very much a male condition. It'd be hard pressed to diagnose it in a female child, but it's possible because it's X-linked recessive. Stairs one at a time is a buzzword. Slower than it appears. They take a long time to develop gait and all of that. And this is Gower signs that they use the hands to push on legs so that they can straighten up and stand up, which is obviously not normal in children to see this. And there's a pseudo hypertrophy of the calves with other shit that isn't muscle because of obviously the muscular dystrophy. So everything else is atrophying and the calves for some reason do this. Do not try to think of the pathophysiology of this stuff. It's a waste of your time. Just memorize the buzzword definitions and you'll be fine. So tuberous sclerosis is probably the one that's probably the hardest to remember all of these things. The way I think about it, it's a bit silly, but tuberous kind of sounds like an adjective you might give to a plant or a tree. Yeah, anyone with me on that one? And then you've got, leaf, green. Makes some sense. There's something there. Look, you figure it out. But basically, it's one of these things called neurocutaneous syndromes, which is basically because of, neurocrest stuff being both skin and nervous system. Cutaneous stuff like these ash leaf spots and shagreen patches, and neuro stuff like seizures, possibly intellectual development, problems with that. There's also other things in other buzzword associations as well. But basically, if you think of these skin things and seizures, it's usually tuberous sclerosis. For another spot diagnosis, anyone know what this is? They have cafe au lait spots, Lish nodules, and these skin things. Which type? 1. Okay, I don't even need to be here. Anyway, neurofibromatosis type 1. Basically, these are the 3 things I'd remember. There's all these cutaneous things like the cafe au lait spots and these neurofibromas. I had an OSCE patient once, like the SIM patient with neurofibromatosis. It was really annoying. Because you want to, say something about that, but it's got nothing to do with why they're in the OSCE. Visual disorders, learning difficulties, and epilepsy. So it's got both central and peripheral and skin stuff. That's what all of these neurocutaneous syndromes are. This kid? Anyone? Everyone happy that this is Sturge-Weber syndrome, Port-Weinstein, and cerebral angioma. So they have both angiomas on the face, but then they've got also things inside the brain. So it's a clue. This is called Sturge-Weber, and it's like 90% almost rates of epilepsy that these kids have because they've got lesions going into their brain, but it can lead to neurovascular complications, learning disabilities, and other problems as well. So it's just about knowing Port-Weinstein is Sturge-Weber, cafe au lait spots, and neurofibromas, which is what that picture was, neurofibromatosis 1, and tuberous sclerosis is the Sjogren and Ashleaf stuff and seizures. So they're all kind of on this neurocutaneous thing. It's important to know the buzzwords for each. Bilateral acoustic neuromas. All right, this is not even fun. Neurofibromatosis type 2, autosomal dominant. It's also associated with other tumors, so it's just a recurrent neurological benign tumors recurrence, but the classic thing is, as the name suggests, there's 2 of them, bilateral acoustic neuromas or schwannomas, whatever you want to call them. Oh, fuck, this wasn't meant to come up with answers. Hopefully no one saw that. Anyone wants to just have a very quick look and tell me what the answers are here? Sorry? Anyone else who didn't see the answers? Thank you. The first question? Yeah? Everyone happy with ADHD? Does anyone have any problems with that? That's not even neurology. 99. I mean, the attention deficit child with hyperactivity has ADHD. Great. 99. Sorry? E. Why? Yeah. And? Yeah, so it's worsening over 3 months. That's the perfect timeline for a tumor. It could be faster, it could be slower, but it's progressively worsening type of thing. It's not a sudden onset problem. It's not an episodic problem because, with migraines, there shouldn't really be too much school performance problems unless she can't go to school because she has so much headache. But complaints of headaches and symptoms worse in the morning, progressively worsening neurology. This is very, very classic of a brain tumor. Is everyone happy with that? All right, very last few buzzwords, worsening ataxia and distal leg wasting. Yep, so this is the Friedreich stuff. So there's the ataxia, and then they get wasting in the distal leg. So that's different to telangiectasia, where there's the immune problems. Symmetrical progressive distal muscle wasting, and this foot. Charcot-Marie-Tooth. Okay, there's no point in me even giving this lecture. A few words before you guys all leave. Look. PEDS really is to this detail. You guys have, a lot of exams coming up. I wouldn't be wasting my time looking at textbooks about these kinds of things. If you know these buzzwords and know what they are and you've memorized this, that's enough for PEDS. Other than RISP, that's the one time when you should, know the asthma guidelines and all that kind of stuff. The rest of, 4th year, it's that's probably where you should be worrying about learning detail. Also, the VIA, don't worry about like year 1 and 2 studying, other than maybe anatomy. It's either too detailed that you could never have studied in a million years, or it's the really classic stuff. The only thing to do is like the day before the VIA, I would say, is remind yourself of everything in the BCP, all the like important things like the types of studies and calculations, the things you can actually study. There was like 3 questions on non-communicable disease facts last year, so memorize that. Remember those like Erickson stages, they will ask those on the VIA, and then really most of your VIA study should be fourth year things. Those were the hardest questions, and not so much peds, but the other stuff. Certainly. Before you guys all go, I know you're all desperate to leave. Anyone have any questions on this or fourth year in general? It'll be over soon, and honestly, final year is the best year of med school. So you'll be done soon enough. Any questions? Well, feel free to come and ask me afterwards. Good luck with everything, guys. Alright, sorry that went a bit over
Oh,
time.
no, you did well. Sorry, guys, just before you leave, we just wanted to say thank you so much for coming. We really appreciate it. We've also put a feedback form on the Facebook page, and we're a little bit annoying. And at the end of it, there'll be a link so you can get access to the OSCEs and any of the updated slides. So we're kind of forcing you to fill it out, but it's just because we want to make the event even better for next year, and we actually read the feedback. So thank you all for coming. We really appreciate it.
Awesome.
And the live stream.